All right, gang, we're back. We're talking about the assessment in the field. This is part 2 of the video. And this time we're going to be talking about the medical assessment part of it. And there's a couple little changes in the medical that we're going to talk about and how we handle it just a little bit different. One thing that I have been preaching in class is that medical patients have a history-driven event. And so therefore, when you're getting a medical assessment, you're probably doing a lot more talking to them versus putting your hands on them. So again, trauma patients is usually hands-on, hopefully while we're talking to them. But the focus is really your hands-on, your physical findings. For our medical patients, a lot of what we do is going to be the talking first and then putting our hands on them. Again, we assure ABCs, or if they're unconscious, CAB, but we start out, again, trying to figure out what's wrong, and we usually obtain a good history in order to do that. So again, your responsive medical patient, okay, get your history first. All right, it's a simple put it. If they're conscious and alert, they can tell you about what's going on. And so it's our job to talk to them to figure out what is going on. All right. Now, your chief complaint, again, that is what is the patient, or in certain cases, what the bystanders have called to request help for. So that is what we're after. It's what the patient says, or what that, in the case of a altered patient, you would say unresponsive, but then or altered mental status, or something to the effect, family states the patient is altered. Those are good things to put in there for those. So again, talk to your patient, get with them, follow your acronym, find out if they're having pain. Again, that's that OPQRST, ASPN, sample. That as actually, if you really stop and think about it, that acronym covers the signs and symptoms. Okay, so that's kind of the subset of sample. All right. Get your history. Your chief complaint is the history adding to this. And then family and social history. Again, so again, if I've got a patient who grandpa died from a heart attack, dad died from a heart attack, and now he's having chest pain, I'm thinking, well, that's a good place to start. It might give us some clues on this. Now, we have gone over this a lot in secondary survey, and remember, there's different questions. One other thing I'm going to say about this, guys, don't limit your questioning because it doesn't fit into this little mnemonic. It's okay. Asking clarifying questions is, as a matter of fact, I think it's a great skill to have, is if something's not clear, you need to make sure that they understand it. On set, what were you doing? Well, I was sitting here. All right. Were you sitting here playing video games? Or are you watching something like that? Were you sitting here, punching each other? Again, these are acceptable questions to ask a person about, did it go to this place? Does it go to that place? Is it the same throbbing when it moves to that place? Those are good examples of clarifying questions. So again, review the systems in a step-by-step basis. And yes, this covers, have you been breathing okay? Have you had any pains in your chest? Any pains in your stomach? Have there been anything around the backside? In other words, has it started maybe in the lower back and has gone around to the front? For females, again, getting the history of their menstrual cycles, especially if you're dealing with an abdominal pain situation, very important. Okay. Or are they already past that point, or have they not even started that point yet in certain cases? Okay. Chest pain, respiratory distress, altered mental status, acute abdomen, all of which are priority patients. Okay. We really need to make sure that it's not one of those things. Okay. We really, really, really need to make sure about that. Okay. If there's any chance that it might be one of those 4 things, it kind of moves us up on the priority list of that patient. And it's so very important to gather that information. So an unresponsive medical patient, one of your quiz questions in the secondary survey, I believe, was that we treat that patient just like a trauma patient. For the most part, I would say yes. The only thing is that we need to obtain history from family or friends if at all possible. And yes, we have to have some, did this patient fall when they passed out? Did they hurt their neck or back when they do it? So it is a lot like a trauma situation. And you should do your rapid head to toe on these people, okay? You really should, because there's, again, did something happen to cause a trauma? The flip of that, all right, maybe not cause the trauma, but did something else cause this issue? And we need to try to find it, if at all possible. Again, your baseline vital signs, of course, very important. I would say probably even more important as soon as you finish that rapid head to toe, we need to get those vital signs, because we're probably going to trend off of what happened. This patient got a heart rate of 20, which is causing the patient to be unconscious. We fix the heart rate of 20, their blood pressure goes up, they become responsive, everything's good. Their blood sugar's 15. Okay, well, and by the way, it's 15 milligrams per deciliter, not millimoles per liter. That's 15. Okay, well, you know what? We probably should get their sugar up. So again, perform additional tests. Consider unresponsive patients unstable. I think that goes without saying. However, yes, most of our unresponsive patients, 99.5% of them probably, are going to be unstable. Okay, so again, what is causing them to be not awake and not talking to us? All right, and if they're unresponsive or they have an altermentation that is not their normal, and I'm gonna have to put a caveat on that, expedite their transport to the hospital. My favorite one is, well, the patient was altered mental status. All right, well, what's their normal mental status? Well, they're normally confused and disoriented, and they sleep a lot because they have Alzheimer's. So what's different today that requires them to be expeditiously transported to the hospital? So again, use your good clinical judgment there. Again, if a patient, especially in our nursing homes where we get a lot of calls to there, well, and my favorite thing is, well, they're lethargic. Okay, guys, lethargic covers a whole range of stuff. Can you tell me what their normal is? And usually the nurse actually doesn't know. The CNA is probably your best bet for finding that information out. What are they normally do? What is different today? And they're lethargic doesn't cut it. Okay, there's things that we need to get from the patients, or the caregivers of those patients. All right. Reassessment. Again, if they change, they start having an altered mental status, they start having chest pain, shortness of breath, any change in the patient condition, always go back to your ABCs. Okay. If they go unresponsive, I would venture to say probably a good place to start is, do they still have a pulse? So again, it's very important to do that. All right. So reassess their mental status. The ABCs are there present, or can it be deteriorating? And yes, it can be. For our stable patients, we usually vital them every 15 minutes, and we reassess them every 15 minutes. If they are unstable, every 5 minutes, and I would say if I've got a hemodynamic problem, I would probably do my vital signs a lot quicker than that. And I would definitely put on devices that could quickly and easily get that for me. I would set my blood pressure cuff to every 2 minutes. I would put a capno cannula on so I get their respiratory rate, okay? These are things, again, that can speed up so that I don't have to sit there and reassess them. Because if I'm having to reassess those things every 2 to 3 minutes, I can't be doing the other thing, which is solving that patient's problem. We have tools and toys that do this. You just use the tools and toys to our advantage. So again, your reassessment of the patient, again, make sure anything changes on that patient. They change heart rhythms. Make sure that you reassess your patient. Hey, how are you feeling? And I've had patients before go into ventricular tachycardia. They look over at me. I feel weird. And I look over at the monitor. I go into VTAC. They're in VTAC. And then I go, well, how you feel? Well, I'm okay. Any chest pain? It's a little sore, but not bad. But I know something's wrong. Okay, perfect. Does that still determine whether the patient's stable or unstable? And that's what we're trying to find out, versus if I look over at them and they're now passed out and I see the nice wide complex tachycardia, okay, well, it's time to grab the paddles and give them a nice lightning ride for going into such a lethal rhythm. So again, make sure that you get all vital signs or fix the life threat in the case of a life threat. And again, do your focused examination again. All right. Double check that thing, especially, and a good example of that is, I know that somebody's got an abdominal problem. Go back and see whether or not I now have a rigid abdomen, hot abdomen. Go back and check these things and evaluate your interventions. Is it something that I did that is causing this problem? Patient's on, I'll give you an example. Patient has low blood pressure, and you decide to give them a liter of fluid. All of a sudden, they said they can't breathe. They're short of breath. You listen to their lung sounds. They're full of fluid. Well, guess what you just did? You probably overloaded them with fluid. Or did their pump start to fail? Again, so I have to reevaluate what my interventions did. And then, again, if it's something I did, I need to start help correcting it. This is especially true when you start giving medicines, especially vasoactive drugs. All right. Again, check your ABPU. And again, falling levels of consciousness is something's going bad with the brain. The brain, remember, gets 30% of the body's oxygen and glucose. So if they start acting goofy and going all crazy, at this point, we got to stop going, wait just a second here. What is causing their brain to start to malfunction? Is it something that I can fix or something I can do things? Double check the airway patency, okay? Especially if you have an intervention in place, okay? Again, if you have an unresponsive patient, again, our gold standard is the having an ET tube in place. All right. And especially if they have no gag reflex. And my favorite one is, well, they're still breathing. We have to RSI them. No, you can intubate somebody without a gag reflex, if they're still breathing. Okay. Now, most of the time, if they're still breathing, probably 9 out of 10 are still going to have the gag reflex. But guys, always prepare for the worst with your airway patency. We hope for the best, okay? Also, don't forget, assure that the air is going in and out. Please assure that the air is going in and out. Our attempts to intubate should really not interrupt that air going in, air going out for very long, okay? It really should not, all right? And again, continue, especially if we have somebody with shortness of breath, we're going to have to watch these guys every 5 minutes and make sure that their breathing's still doing good. Pulse rate, rhythm, and quality. Again, we want to make sure that that's there. If we got a falling rate, double check your oxygen saturations. Check that the patient is in shock. And again, it's the terminal stage of shock when they start to slow down, usually because of poor oxygenation. By the way, the number one way to fix bradycardia is good oxygenation and ventilation. All right. Sudden changes in rate, rhythm, or quality, probably a cardiac dysrhythmia. Again, if we don't have them on the monitor, we hopefully will have them on the monitor very, very quickly. And then if you lose peripheral pulses, the patient's probably going into a shock state. More importantly, they're now decompensating. They're getting worse on you. Skin signs tell all. You got a patient that was pink and all of a sudden they go pale, cool, clammy. Start reassessing that patient immediately, okay? Pale, cool, clammy skin just doesn't happen by chance. It happens because of reasons. Is the patient shunting blood? Are they nauseated and getting ready to throw up? Which again, now causes an airway problem and interthoracic pressure, which can cause cardiac dysrhythmias. All of these things can happen, all right? Skin signs tell all. Most people don't walk around extremely pale, cool, and clammy. Maybe a little bit pale because they have not enough red blood cells, okay? But then we got to start figuring out what is causing that person to not be pink, warm, and dry. All right? Again, transport priority based upon the patients, and this can change, okay? So if you've got somebody that's unresponsive that now is responsive because their sugar was down, you now got an IV started and you gave them appropriate amounts of dextrose, and now they are very stable. Can I turn the lights and sirens off? The answer is yes. Yes, you can. Okay? You can upgrade or downgrade based upon your assessment and your impression of the patient. Are they trending, getting better? where they're not going to get worse. Okay. Yes. And you can downgrade your responses, by the way, guys. Absolutely you can. All right. We talked about all this stuff already. And again, management plan. We don't, in the nursing world, you write out a treatment plan. Our treatment plans are loosely based off of our standing orders. But again, one size doesn't always fit all. Okay. Consider another, and if what you're doing, by the way, is not working, don't keep, the definition of insanity is doing the same thing over and over and over and over again and expecting a different result. So again, if what you're doing in your interventions are not working, really take that step back and go, wait a minute, something's not right here. Okay. Something is not right. Be flexible, be ready to change your course of action. I told you guys about the patient who I thought was just being a belligerent individual. I ran on him multiple times. He was just an absolute jerk. I'm like, you know what? I'm not dealing with you today. I gave him 5 of Haldol. 2 minutes later, instead of him being happy, he was still that same jerk. And I kind of went, wait just a second. Something's not right. And I reassessed the patient. And as a matter of fact, I put him on the Capno. And the second I put him on the Capno, oh, it's 70, almost 35 to 45. This guy's hypercapnic. No wonder he's acting like this. 10 minutes later, I'm intubating him. And then I found out he was really super hypercapnic. So again, it was a flexible course. And I remember going into my medical director and going, yep, I screwed up. And I told him exactly what happened. And he was like, well, the good thing is you caught your screw up. I said, yeah, I guess that's a good thing. Everything about this course is teaching you this right here. Clinical decision making. Form a concept. Interpret your data. Apply the principles. Evaluate the results. And then reflect on the incident. Okay? By the way, I'll flip another one of that. Evaluate your results, and if need be, go back up to form a concept and data. Okay? A good paramedic knows when to change course. All right? A good paramedic also knows when to stay the course. Now, when do I do that? Well, that's what we're going to be discovering together over the next year of classes that we're going to be taking. But the biggest thing is if you keep doing the same thing and the patient's getting worse, it's time to think about something else, because usually when we get a patient, we start working on things, they usually trend in the better direction. If they're trending in the opposite direction, there's something else that we didn't catch and we need to catch it. And again, the way that we catch things, get your concept, try to figure out what's wrong, get the history of the patient, find out what happened, conduct a good physical examination of that patient. So now we know what it is that's probably causing the problem and we start to fix it. But also remember that it can not only be one thing, it could be 4, 5, 6 different things. And if go with the thing that we think it is first, and if that's not working, then we go to the second thing or the third thing. Okay. I call this the zebra theory. A lot of the residents that you see and they're starting to treat patients, they're a brand new doctor, they'll be looking for the zebra. When a lot of times it's a Western on TV. Okay. It's a horse. And yet we try to make it into more than it is. Okay. So again, look at all the things that's going on with the patient, go with the most obvious, understand that there might be other things involved, but go with the most obvious to start fixing their problems. And from there, we kind of determine our field diagnosis of the patient, what it is that we think is wrong with the patient. Now, that's what you're going to be doing a lot of in your clinical rotations and while we're doing scenarios. And that's what we're after. Can you pick up what's wrong with the patient? And by the way, we have scenarios, guys, that intentionally mislead you about one thing, and we see if you go down the rabbit hole. Okay? The good news is if we kill pieces of plastic, we're okay. It's all right to do that. All right? So again, apply your principles. Think what it is. If I got a patient that is hypovolemic, again, how do I fix that? They've had diarrhea for 3 days. They've had a gastrointestinal infection. Now their blood pressure is low. Their heart rate is high. How do I fix that patient? Usually I put a bronze dagger in one arm and I start flowing that IV wide open, making sure that they're not overflowing in their lungs. Okay. And then I evaluate the results. Hey, you know what? I gave them a liter of fluid instead of blood pressure of 70/40. Now it's 90/60. Their heart rate went from 140 down to 130. Hey, you know what? But they're still bone dry. Let's give them another liter of fluid. Give them another liter of fluid. Hey, now their blood pressure is 130/60. Their heart rate went from 130 down to 100. Okay, you know what? We've got them out of the danger zone. We've evaluated our results, okay? That's how you do it. And then don't always, as a matter of fact, we're going to do a lot of this. We're going to reflect on the case. We're going to take a look at it. We're going to say, hey, what is it that you did good? What is it that maybe you could do better next time, okay? Guys, video replays, by the way, are an excellent example of reflecting on your case, okay? So that you can see in a slow time of what happened, and so that you're better prepared for the next time that this happens, okay? With every patient contact you guys get, your experience will grow and your judgment will improve, assuming that it doesn't sneak into complacency, okay? But the more that you see, the better of a clinician you're going to be, okay? The more that you see, the more experience you get, and the better you're going to be at finding problems, okay? That's going to do it for this. And again, this is just a small summary about what happens with the patient. And again, the long and the short, guys, it's so very tough when we're teaching this of putting everything together. We taught you the individual components, and now we're at that stage where everything meshes. And then we try to fuse all of these clues, all of these toys to figure out what it is that's wrong. And as we go through the rest of the class, that's what we're going to be doing. We're going to be studying what happens when the heart rate goes too slow. What happens when they're in VTAC? What happens when they get a gastrointestinal infection? All of these things is what we're going to be studying together. All right, that's going to do it for this one. I'm going to see y'all guys on the next class. See ya.